Welcome to the Metabolic MD. Health means everything. We all seek optimal health, but most of us do not know how to achieve it. Dr. Paul Kolodzik has spent a career in the emergency department. Now, he helps his patients avoid ever ending up there. During these podcasts, you'll learn how you can lose weight and prevent and reverse disease through new technology, a modified diet, and the use of some new recently approved FDA medications. This information is not meant to be medical advice. Please seek consultation from your own medical provider. Let's listen in.
We want to thank our following sponsors, themetabolicmds.com, a boutique weight loss practice focusing on weight loss through modern technology, the latest GLP-1 weight loss medications, and health coaching. We also want to thank the CGM Doctor, where you can purchase a CGM without a prescription delivered right to your door and also find useful information to get the most from your CGM to improve your health and weight.
Hey, Dr. Paul, welcome back for part 2 of this thing, Rethinking Your Drinking. Yeah, we were creating a title for that. We had so much information that we couldn't get it all in the little span of time that we have for a podcast, so we had to make this part 2. Where did we leave off? Do you remember?
Well, we were talking a little bit about the abstinence versus harm reduction approach.
Meaning cold turkey or...
Well, abstinence doesn't have to be cold turkey.
Just saying,
you can work through detox and into rehab and then pursue long-term abstinence.
Because I've always heard, if you're an alcoholic and you take a drink, every movie shows you're just going, that's it. You're. Well,
first of all, the term alcoholic isn't used anymore. Not in medical terms. It's alcohol use disorder, AUD.
Can I make a statement here right now on this podcast? This is and I'm not on the red hat team at all, but that's a very woke thing, right? I hate that crap.
So,
but keep going.
Actually, there is a book that classifies psychiatric disorders, and so this comes from that. It's scientific and medical. It's not necessarily woke.
Is that supposed to make somebody feel better? It doesn't.
Yeah, I don't know what to tell you.
Okay. Get off my soapbox.
Yeah.
Talk about the abstinence thing that you see in movies. If somebody takes one little sip, that's it. They're back on the back.
I think, first of all, I don't want to suggest to people out there that I am not pro-abstinence. Abstinence is the best approach for anybody that's ever had a problem drinking.
Yeah.
There's no question.
Okay.
But I think other approaches can be better than a cycle of abstinence followed by severe drinking, followed by abstinence, followed by severe drinking.
Because that's what you hear most often. That's the pattern that you always see on TV and in movies.
Right. So the point I'd like to make here is that, Alcoholics Anonymous, which is kind of, what's known as kind of the abstinence approach.
You get chips and coins or like a fire.
Yeah. I mean, and I think AA has done innumerable people an immense amount of good over many years. And then AA has a tendency to be more faith-based, believing in a higher power. There are some people that are a little turned off like that. There's an alternative called Smart Recovery, which is a similar approach, but not necessarily as faith-based. And, there's all kinds of options for these abstinence approaches on the internet now. There's all kinds of, internet programs or groups that you can be involved in. So it's not necessarily that you have to go to a local meeting anymore, though I think that can be very good for people as well.
Is it one of the very first things you have to stand up and say, I'm Terry O'Brien and I'm an alcoholic or whatever? You have to admit your problem?
Yeah.
Is that do you guys do that in the hospital as well when somebody's admitted?
Well, I mean, people usually come to us because they've admitted there's
because they know it. They're already admitting it by coming there.
Yeah.
Okay.
Yeah. So there is that abstinence approach, but I'm going to just throw out a thought for people to consider. So abstinence has been the approach for alcohol management since the 1930s.
Yeah,
right?
I would agree with that.
Terry, do we treat heart disease the same way we treated it in the 1930s these days? Do we treat cancer the same way we treated it in the 1930s?
No.
No, we don't. So, to at least consider that there are other approaches like medication-assisted treatment or harm reduction, I think is an appropriate consideration.
Go to harm reduction first, because that one's I know where we're going to go with the medication treatment, but tell me about the harm reduction. What is that?
It's just gradually decreasing the amount of drinking you're doing so there is less risk to your health, and also, reduces risks associated with your relationships, with your work, with, driving a motor vehicle while under the influence of alcohol. So instead of necessarily becoming completely abstinent, you realize that you want to go from a higher level to a lower level and manage that. I mean, you could go from a high level of drinking to a harm reduced level of drinking. That is normal.
Doesn't that take a lot of willpower?
This is why I'm a big fan of medication-assisted treatment.
Okay.
Because the answer is yes, it takes some willpower, and we'll talk about some of the behavioral techniques that are important as part of that process. But medications can help, and in particular, I use a medication called naltrexone. There are now 3 FDA-approved medications for alcohol use.
All right.
Okay. The first one is the oldest one. It's called Antabuse, and it's a medication you take, and you take it every day. And then if you drink while you're on this medication, it makes you sick. You start vomiting.
Really?
So it's a negative reinforcement approach.
And that's an old school?
That's an old school, and I haven't ever prescribed that.
Okay.
Because some of those reactions can be very severe, and secondarily, that's kind of a punitive approach.
Well, yeah,
yeah. And the other thing is that people got to take the medicine every day, or it doesn't work.
Okay.
So people are thinking, if I want to drink, well, I'm just going to skip my medicine today. So Antabuse is the first medication. There's another one called Camprel, Camprel, or acamprosate is the generic name. And it helps with reducing alcohol use. It's not a miracle drug, but it helps. But the problem with Camprel is you got to take 2 pills 3 times a day, every day.
2 pills 3 times a day?
Every day.
Is it expensive stuff?
I don't think it's necessarily real expensive.
Okay.
But it's just hard to maintain compliance.
But how does that differ from the first one?
Camprel doesn't make you sick when you take it.
Okay.
But it does help reduce alcohol cravings.
So it's a cravings thing.
Yeah.
But where we get to GLP-1s, that's kind of partly that, isn't it?
That's part, yeah.
All right,
yeah.
So what's the third one?
The third one is naltrexone, which is the medication I use routinely.
And how does that work?
Okay. Naltrexone is a brain chemical blocker. So it basically attaches to the dopamine receptors and the opiate receptors in your brain, has an influence on serotonin in your brain. And so it blocks the pleasurable response that you get to alcohol, you get from alcohol if you take it while you're drinking. So it kind of mutes that positive reinforcement.
When you just drink more to
get
kind
from
of
alcohol.
No,
people have a tendency to realize over a period of time that they aren't going to get that positive reinforcement. So I use naltrexone. There's a couple different ways you can use naltrexone. So first of all, it comes as a shot called Vivitrol, which is a 1-month shot, which can help reduce alcohol craving.
A 1-month shot? How long has it been out?
Vivitrol's been out probably 10 years, maybe more.
Yeah, my brother passed away 20 years ago, so wouldn't have helped. I wish he had something like that.
Yeah. So Vivitrol helps, but I like to use, and then you could also take naltrexone on a daily basis as opposed to getting a shot. You take it every day. But, again, you got to take it every day for it to work, or
Right.
it doesn't work. I prefer to use naltrexone in a method called the Sinclair method. So the Sinclair method was developed by Dr. Sinclair. And the way you use naltrexone as part of the Sinclair method is you take you take a pill an hour before you're going to drink. So you're going to have you drink in the evening. People have a come home from work or whatever, and it does just what we talked about. It mutes the response to alcohol in your brain. So when you drink, you aren't getting that positive reinforcement as much. And then that is contrasted with days you don't drink. We monitor and encourage what we call alcohol-free days, or AF days. So you have days where you don't drinking and you aren't taking in the naltrexone, and we encourage people on those days to do something pleasurable, take the dog for a walk, work out, whatever is pleasurable for you. So what happens here is that your dopamine and serotonin and opiate receptors in your brain get muted when you're on the medication and you're drinking. And then on days where you're not drinking, you are not taking the medication, and you're letting those receptors kind of run free in terms of positive reinforcement.
All right.
And so then there's a learning process over a period of time where your brain learns that, I can have great, very pleasurable days without alcohol.
So in your experience, because this is one of the areas you're practicing in, is the shot more likely to work, or the daily plan thing?
I think the Sinclair method is the most effective method,
which is taking the pills.
Yeah. And then if you couple that with what I think is going to be the next approved medication for alcohol use, one of the GLP-1 medications, I think it's going to be the most effective combination, the most effective combination approach to help reducing alcohol use that really we've ever seen. Now, the semaglutide, the GLP-1s are not used commonly because they aren't approved for this reason yet.
And tell me how they actually affect the people who are drinking. What's going on there?
So I'm not an expert in this area, but I do know from my work with patients that are overweight and obesity that semaglutide, GLP-1s have three primary effects. They help with weight loss because they lower blood sugar.
Right.
They also slow gastric emptying, which means your stomach stays fuller longer.
Yeah.
That could have some effect on the amount that you're drinking. But the big effect really is on the hypothalamus in the brain, the satiating center of the brain. And so I think that's probably where the GLP-1s have their biggest effect related to alcohol use.
So, I mean, as a diabetic, the worst thing you can do is send me to a birthday party, right? There's that cake.
We should give you naltrexone before you walk in.
You should. Well, I'm trying to relate to...
Naltrexone, I got to mention, naltrexone has been approved as a weight loss medication as well.
Really?
There's a medication that is basically naltrexone combined with a psychotropic medication that has been shown to decrease food consumption. So the medication is actually naltrexone with Wellbutrin, which is a type of SSRI, kind of antidepressant, anti-anxiety medication. And it was marketed as Contrave, Contrave. So before the GLP-1s hit, Contrave was one of the more popular weight loss medications. And again, I think it can be helpful, but I think only, moderately so.
So dig into this GLP-1 thing just a little bit. I know there's two brands of GLP-1s out there. We are not going to talk about brands. One is shown to have a little bit better effect in weight loss, right? And do you think that would also relate to a better effect in reducing alcohol?
Yeah, they haven't been studied that extensively yet,
okay.
So I can't say. I think that it's semaglutide that has been used mostly in the alcohol studies, which are ongoing.
How long does a study take?
Well, I mean, to get a medication FDA approved can take years.
Okay.
So,
but if a physician thinks like yourself, if they think it's possible solution and it's approved for other things, are you allowed to prescribe it?
You're allowed to prescribe it. That's used off-label. You got to make sure that the patient understands that it's not, it hasn't been approved by the FDA for this. The studies are not complete, etc. So there's kind of a, risk-benefit discussion that takes place. But medications are used off-label all the time.
Okay.
Let's talk about the behavioral stuff.
Are you talking about me personally?
No, because we don't have that much time left in this segment.
All right. So what do you mean by behavioral stuff?
Okay. So I don't wind people up and say, here's naltrexone, good luck with it.
You're talking about the follow-ups?
Okay. Or here's naltrexone and semaglutide, good luck. You still got to roll up your sleeves and do the other work related to what are we going to do to control your alcohol.
You're talking as a physician or as a treatment?
Yeah, I mean, this is the way I've treated patients for 10 years.
You're not talking about the patient itself. You're talking about what you do.
Well, I'm talking about how I collaborate with the patient.
Okay, so go ahead and walk through that.
To manage your drinking, okay?
Yeah.
Right at the top of the list is keeping a drink log. Okay.
Do people do that?
Yeah. I got patients that have just been great with keeping their drink
logs.
logs.
What does that do?
It allows you to journalize. You know how in psychology, psychiatry, journalizing, writing down your thoughts, your activities for the day, whatever, can be very helpful.
I've never done this, but keep going.
Okay. Well, maybe
I should.
So we're just asking people journalize, and there's all kinds of apps out there, basically literally take you 3 seconds a day to write down your number.
Oh,
of
in
drinks.
Your cell phone. Okay.
Yeah.
All right.
So keeping a drink log is right at the top of the list, because then you can follow your drinking patterns. And you can see, what are the situations where I'm drinking more? How can I address that? You can get satisfaction from the progress as you see your drinking amount coming down. So every patient needs to make a drink log.
So can I ask a real quick question about that? Have you ever found, and this is just what I think people would do, they don't want to get yelled at by their doctor, so they're going to kind of not give you the truth.
I'm sure that happens. But
and how do you make people understand? I'm not going to yell at you. I don't want to make you feel like you failed.
All depends upon the rapport that you have with the patient. But again, my patients are self-selected. I'm not pulling people off the street that drink too much and saying you need to do this. They come to me because they want help.
Okay.
And again, the vast majority of the patients that come to me, whether it's personal preference or whatever, their initial goal usually is an abstinence. It's just like, let's get my drinking under control. I want to drink less. And my answer is, that's fine. Let's get your alcohol use down, and then you can decide to be abstinent or not abstinent. But again, most of the people just want to control their drinking.
All right.
And I got to tell you, we've been very, very effective at that. I'm not going to say that, in every patient, they're cured of their excessive alcohol use. But in the vast majority, we reduce alcohol use very, very significantly.
I'm excited to hear this.
Yeah.
Okay.
Yeah, because, again, and it's a combination of the medications and the behavioral techniques. So the other thing that's very important in addition to the drink log is collaboratively setting goals. And this is like a continuous, what do they call it? Continuous quality improvement, like in manufacturing. It's like you don't try and solve world hunger out of the gate the first week. Okay, you don't try and go. First of all, that can be dangerous because of the withdrawal issue.
Sure.
Yeah. So one benefit of harm reduction is this gradual diminution in the amount that you're drinking.
You just use a fancy word. I'm sorry, please.
Okay. This gradual approach of drinking less and less over a period of time.
Thank you.
Okay. Which can be helpful because then the patients really are not put at risk for, these withdrawal symptoms or complicated withdrawal that we talked about in the last segment.
All right.
So I think that's one of the benefits of, this outpatient medication.
Give me an idea of a goal. Just tell me real quick, maybe a goal you've heard that seems like reasonable. Tell me what I come to you, I'm drinking. Give me my first week's goal.
Well, it's individualized. How much are you drinking to start? Tell me how much you're drinking to start.
16 drinks. I've exceeded the drink limit by
16
one.
drinks a week?
16 drinks a week.
Okay. And your question is?
I want to drink half.
Yeah, sure.
Is that my goal?
What?
Do I write that goal down?
That's your initial goal. Again, it's a continuous quality improvement approach.
Do I ever graduate where I said, okay, I've done my goals, I'm out of here, this is great?
So then we get you to 8 drinks a week.
Yeah.
And we have a discussion. Is that where you want to stay? Are you happy there long term? It's within the guidelines.
Okay.
Let's back off on how frequently I see you. Let's touch base every 3 or 4 months to make sure that you aren't having you aren't regressing.
Right. Okay.
So, but it all depends upon where you start. Again, so my guy that was drinking 35 beers a day. So it just interesting.
I don't know how you even afforded that.
Well, I'll tell you. First of all, he was a big guy. He was about 400 pounds. Okay, and he was going through a divorce. Him and his wife were still living together.
Oh, man.
He would come home from work and he would sit out in his van listening to his radio. I mean, this was at that point. I mean, he was probably online too. But just, drinking beer until she went to bed and he would go inside.
God,
then,
I feel so sorry for that. That's awful.
Yeah, I felt bad. He did great, actually, because when he lost all kinds of weight when he reduced his alcohol use as well.
I thought he lost weight when he got rid of his wife.
Okay. The old ball and chain thing, is that what you're talking about?
So he reduced, once he eliminated that stress.
Yeah. So he initially got down to, so he went from 35 beers a day to about 3 or 4 beers a day.
Really?
And then we got him doing some alcohol-free days because it was safe at that point. So I think ultimately he ended up getting down to like, 15 to 20 beers a week or something like that.
So because he was overweight, was he also semaglutide patient, or did he?
Yeah, he wasn't on semaglutide. This was before the weight loss drugs were out.
Okay.
Yeah. So the other behavioral techniques are what I just kind of alluded to is we set goals. It's like, okay, these are the types of goals I usually set with patients. Number one is let's select days of the week where you're going to be alcohol free. Let's select a few. You've been drinking every day. Let's now try and work in a day where you don't drink. Okay, let's target it. And then let's try and work in 2 or 3 days a week where you don't drink. So that's one approach we take. The other approach I take is what I call a drinking window. Okay, when do you usually drink? Well, people say, well, I come home from work and I walk in the door and, I grab a beer at 5 o'clock and I'm drinking until 9 o'clock. Okay, so let's reduce that drinking window. Tell you what, walk in the door and let's decide what else you can do. Maybe take your naltrexone when you walk in the door, which means you can't drink for an hour. You need to wait an hour. Maybe take the dog for a walk or something like that, or, decide what you're going to do. But let's shrink that window. And you know what? Let's try and shrink the other end of it as well. So instead of your drinking time being 5 to 9, let's make it 6 to 8. So we gradually whittle away at that drinking time. So, and then the other thing we do is we set overall limits. You generally a daily limit and a weekly limit. So we'll set a daily limit as, let's say you're never going to drink more than 3 drinks in a sitting. You were formerly drinking 5. Now we're going to reduce that to 3. So we have these series of goals that we set over a period of time. And, do people meet them all the time? No, it's not perfect. But we gradually, again, continuous quality improvement, keep putting one foot in front of the other to reduce their use over time till we get them in a position if they want to become abstinent, they can. But again, I'll tell you that most of my patients want to just drink less.
Well, so again, we're coming to the end of this podcast. We may need to come back at another date and keep going, because this is an area that's fascinating. I mean, it's just like, if you can improve somebody's life like that, why not?
It's fun to see people that are doing very well, and it integrates into the whole metabolic health issue as well, because when people are drinking less, they're getting healthier. They're often losing weight, as we mentioned, the one gentleman, and they're getting healthy. They're avoiding the toxic effects of alcohol, which at excessive levels can be very significant, whether that's gastrointestinal or liver or, risk to the brain in terms of dementia. So it integrates into the metabolic health issue as well. So, I mean, part of overall metabolic health is making sure that your alcohol use is under control.
All right. Well, we're going to land this one again. Dr. Paul, thank you for your time today. You want to plug anything before we go?
Terry, you tell me, Terry, the book, the website, we're good.
The book, the website, the practices. We've got so much to say and so little time to do it. All right, folks, thanks again for joining us here on the Metabolic MD with Dr. Paul Kolodzik. I'm Terry O'Brien, your producer, and we'll see you again on another podcast.